Okay, so I'd like to start the session, clinical high-risk MDS. First speaker of this session is Dr. Fenaux, and Fenaux will give us a lecture online. The title of his talk is Overview of the Treatment for High-Risk MDS. Dr. Fenaux, are you ready?
So good morning to everyone, or good afternoon for you. And so and thanks for the invitation. And so the talk will be on overview of the treatment of high-risk MDS. So what we all know, of course, do you hear me okay?
Yeah, we can hear you.
Okay. So we all know, of course, MDS is a disease in the elderly. So of course, this with a median age of about 70. So of course, this is going to influence treatment, especially as we know that allogeneic stem cell transplantation remains the only curative treatment so far. So I will first try to see what is lower and high risk MDS, where is the limit. We used to make the difference between high risk and low risk MDS by the IPSS and then the revised IPSS, we all know. And generally speaking, high-risk MDS includes patients with a revised IPSS greater than 3.5 points. And in those patients, survival is poor. And we definitely need to delay disease progression and prolong survival, which may be different in low-risk MDS. So this includes, therefore, a very high and part of the intermediate revised IPSS. Which we include in high-risk MDS. Now, of course, this has somewhat changed with the molecular IPSS, which, as you know, is based on 16 genes, and is going to change things a little bit, and more than a little bit, because it worsens the outcome in part of the patients who become very high or high risk by the molecular IPSS, although they were considered low risk by the revised IPSS. I think one of the problems is that so far, most drugs have been approved through the IPSS or revised IPSS, not so much in the molecular IPSS. And in addition, I think we lack long-term follow-up to, for example, to decide that we're going to transplant a patient just based on mutations, except probably TP53 mutation, which has a very poor prognosis, and on the other hand, SF3B1 that has a better prognosis. But apart from those two, I mean, it for me remains difficult to make decisions just based on mutations. Now, things have been somewhat compounded by the coexistence of the new World Health Organization classification, the WHO classification, and the ICC classification, which, in addition to the revised ELN1, so it's a bit complicated. But this has, as you know, introduced a group of patients between 10 and 20% blast that could be considered borderline between AML and MDS. And this is based in particular on those patients having MDS type mutations like the one here, seen here, ASXL1, BCOR, EZH2, RUNX1, etc., or having MDS-like karyotype, including DER5Q, monosomy 7, trisomy 8, etc. So it introduces a group in between, which once again can be discussed, but at least it may allow patients with 10 to 20% blast to have access to drugs that are only approved for AML. So it may be good for them. Okay, so this is the treatment algorithm in MDS, in high-risk MDS, which was designed now more than 10 years ago by a group of investigators. And for high-risk MDS, the suggestion was to perform transplant whenever possible, preceded or not by cytoreduction, and if there was no possible transplant, to allow for either intensive chemotherapy or azacitidine in those patients. And of course, very old patients, well, were treated symptomatically, but there are very few of those patients. The problem now is that there's no clear change in that algorithm because we have no extraordinary, we have not made extraordinary improvements in the last 10 years. So I will first focus on transplant because it remains the only curative treatment. So who are we going to transplant when? So I think there's clear indication that patients with high-risk MDS benefit from transplant. And there are at least 3 prospective studies that compared patients with a donor and without a donor, and in the idea of intent to transplant with a benefit for transplant. On the other hand, several studies have shown that patients with lower risk MDS probably did not benefit from transplant, and in those patients that delayed transplant was better. Those were not randomized studies, of course, and even not compared between a donor and a no donor, it's not obvious. And in addition, especially with the revised IPSS, the patients who are in between, like the intermediate one, are a bit difficult to classify. But in a way, you can always wait to some extent before transplanting, but then patients may relapse. It's always difficult in between to draw the line. Now, what is interesting also is that, as we said, the median age is now above 70 in MDS, and there are several studies showing now that even patients above the age of 70 can benefit from transplant. This on the left is a paper published in 2017 showing some potentially interesting survivals in those patients. And in the right, this is the experience of the group of Marseille in France, showing that if you properly select patients above the age of 70, you even have I would say a fair survival, which is in the present case about 50%. And of course, those are highly selected patients, and we generally don't go above the age of 75 or so, except for very few patients who are very fit. But so we know that transplant has improved due to the better matching of donors, and also by in particular prevention of infections post-transplant. So it's good news. Still, even we all know that when we see publications on transplants, they often include patients transplanted 15 years ago, especially EBMT, IBMTR. So I've just shown here the 2 recent experiences by the GFM in two trials that included transplant. So those were patients transplanted less than 5 years ago. And even in those patients with the median age and the 2 trials of 62, as you can see, the transplant-related mortality was 17% in one, 19% in the other. Patient numbers were relatively limited, but still, I mean, transplant-related mortality remains relatively high, even in recent trials. So, I mean, it's always, as we all know, a difficult decision to go for transplant. Now, there are patients who may not benefit so much for transplant. And as using the revised IPSS, we can see that patients with very poor karyotype have a very high relapse risk on the top left. On the top right, patients with TP53 mutation, and this is generally biallelic TP53 mutation, have a high relapse rate, although it's probably better than not being transplanted, but the relapse rate is very high. Now, on the bottom panels, what is interesting is that patients with high risk who are not biallelic TP53 mutation really benefit from transplant, as you can see if you compare patients with a donor and non-donor. So it's an important message. Those patients with unfavorable mutations in particular do benefit from transplant. So we are faced with the main group in whom the relapse rate is very high, and this is the patients with biallelic TP53 mutation, who, as we all know, have generally complex monosomal karyotype. Now, there could be some groups where the evolution without transplant may be as good as with transplant. And it could be that the DDX41 patients overall fare relatively well without transplant, and transplant-related mortality may be relatively high in some series, so and offset the benefit. So we need more patients to define that, but patients with DDX41 mutation, which as we know is the most frequent inherited mutation in AML and MDS, may not so much benefit from transplant in many situations. Now, the donor, I mean, the good news is that we all know now with new series is that haploidentical transplant does almost as well, and even in some series as well as matched sibling or 10 out of 10 matched unrelated donor siblings, so unrelated donor. So which means that almost all patients now have a donor, which is very good news indeed. So with an almost similar outcome. What about treatment before or after treatment? Transplant. This is highly disputed. There are no prospective studies, and it's never been possible to carry out prospective studies in this context. So it's often suggested that if you have less than 10% marrowblasts, you should go for transplant. If you have more than 10 marrowblasts, it's more disputed. Some may go for upfront allo, provided it can be performed rapidly, and this generally means a sibling or a haplo identical donor, because unrelated donors are often more difficult to select. And overall, when karyotype is favorable, intensive chemotherapy may be selected, and probably when unfavorable karyotype, there is unfavorable karyotype hypomethylating agents without other drugs, and we'll see. Now, an example in patients with generally normal karyotype, this is CPX351, which you may, in this situation, may be somewhat better than the 3+7, and this was the French experience of the GFM by Peterlin. 31 patients, and 29 of them could be bridged to transplant. So the impression is that intensive chemotherapy, perhaps, I mean, it may be the only indication remaining for intensive chemotherapy, at least in my view, for high-risk MDS. And in fact, at least 52% of those patients reach CR, but also 13% CRI. So most patients eventually can be bridged to transplant. But we have to bear in mind that almost all patients had normal karyotype or a single normality and not unfavorable. Now, what about hypomethylating agents, especially azacitidine? This is the trial we all know, AZA-01, that led to approval of azacitidine in many countries. The problem, as we all know, is that in that trial, the CR rate was only 17%, the PR rate only 12%. Most patients just had an improvement in cytopenias with no clear improvement in blasts. And this may not be a very good situation prior to transplant if you don't reduce the blast count. And indeed, another study, a German study, found in patients who were treated with azacitidine, who had advanced MDS, that only 10% achieved CR, 17% PR, and most remained stable in terms of blasts, and many could not proceed to transplant. So perhaps a better approach could be the combination, especially with azacitidine, with venetoclax. We still don't know, I'll show it later, if this combination improves survival over azacitidine alone, but at least it leads to, in the experience recently updated at ASH by Dr. Garcia, it leads to blast clearance in at least 80% of the patients, and obviously is less myelosuppressive than intensive chemotherapy. So this is certainly an interesting approach, at least before transplant. And we know now, we have some experience in AML with this regimen is capable of bridging a lot of patients with transplant with interesting outcome and favorable outcome post-transplant. And so it may replace intensive chemotherapy in many situations, at least in the elderly. Now, is it useful to have a treatment post-transplant? Now, this is a randomized study showing that azacitidine, at least overall, does not seem to bring a benefit as compared to observation post-transplant. We just finished at the GFM a trial where we use azacitidine prophylactically in high-risk patients, especially TP3 mutation. We don't have the results as yet to see if there is a population that may benefit from this maintenance treatment. Now, relapse, we know azacitidine has been used followed by donor lymphocyte infusion in this situation, and there are studies showing that some patients definitely benefit from this situation, with here survival at 3 years of about a little more than 20%. So a small group of patients may benefit. What about azacitidine plus venetoclax, or at least HMA plus venetoclax? Well, this is a meta-analysis on the left showing but this is for relapse on the left, showing a CR/CRI rate of 32% and a survival at 1 year, which remains modest at 23%. And on the right, prophylactic azacitidine plus venetoclax showing once again, 50% survival, but we lack follow-up. It's not randomized, but it may be an interesting approach, at least in high-risk patients. But we need to define that better in patients at high risk of relapse, especially, as we said before, biallelic TP3 mutation. Now, conditioning, it's always the question in MDS, should you have reduced intensity conditioning or a more conventional one? I mean, this is one study, but I think all studies are overall about similar. We know that more intensive conditioning leads to higher transplant-related mortality, and lower intensity conditioning leads to more relapses. So overall, survival generally appears to be the same. So it can be discussed, but I think our colleagues, particularly involved in transplant, tend to tailor the conditioning based on age, comorbidities, etc. Okay, so now hypomethylating agents. Once again, I have no chapter on an intensive chemotherapy because my impression is that it's mainly interesting before transplant. So, well, we all know the results of this AZA-01 trial I showed before, with a median survival of about 2 years, better than conventional treatment, but remaining, of course, modest. And what we all know also is that response in those patients is delayed, and often 3 or even 6 cycles, which means a period during which the patient has prolonged cytopenias, is very much transfused, which is quite cumbersome for the patients. And as I said before, most patients do not achieve a CR or PR, only 17% CR, 12% PR. Half of them just achieve an improvement in cytopenias, that is, transfusion independence, improvement in platelets in those patients. What we know is that in real life, the median survival is probably more about 18 to 20 months, as showed on the left in the Spanish experience, where mostly patients with monosomy 7 benefited on the Canadian experience on the right, a median survival of about 20 months. What is very important also is that in the absence of transplant, long-term survival is very poor, about 4% with both azacitidine and decitabine. So this is obviously not a curative treatment. So what can we do to improve outcome? First, there are the oral hypomethylating agents, oral azacitidine, decitabine, as we know. Those drugs are convenient, but so far there's no proof that they improve overall survival as compared to classical azacitidine or decitabine. But of course, the main issue is to combine them with other drugs. So this is the experience with Aztec 727, which is overall an oral form of decitabine, which has the same pharmacokinetics and the same results. So it's approved in many countries. So it's obviously more convenient than the sub-Q or IV azacitidine or IV decitabine. Now, we also know that CC486, the oral azacitidine, leads to this was in a group of patients with intermediate risk MDS, obviously gave better results in terms of erythroid response as compared to placebo in those patients, but that was a myelosuppressive drug in this situation. We have limited experience with the other Aztec drug, which just started phase 1-2 trials. Now, of course, the idea is mostly combinations. What we've seen in the last 10 years also is that many non-randomized trials showed potentially promising results, using idarubicin, HDAC inhibitors like vorinostat, panobinostat, and lenalidomide, check ruxolitinib, rigosertib, gentusumab, and overall, I mean, this was quite promising in terms of response rates. But now when it came to randomized trial of those combinations compared with an HMA alone, they all proved negative so far. And this is a list of, I would say, negative studies published by many groups in terms of survival. This was disappointing. Even with more recent trials on the right, pevonidostat, which is a nedylation inhibitor, which appeared interesting in a phase 2 randomized study and negative in the phase 3 study. Sabatolimab, the jury is still out because there was no obvious overall benefit in a phase 2 randomized trial. But it appears that responses may be longer with sabatolimab, and there's an ongoing, I mean, there's a phase 3 trial whose results we don't have completely. So I think for sabatolimab, the jury is still out. Magrolimab on the right bottom also proved negative, CD4/C7 inhibitor. So and the study was recently stopped. There was also the issue of drugs reconforming mutated TP53. And for example, this drug, eprenotaptopus, that is APR246, was apparently interesting in a phase 2 study, including by our group and a US study, with a response rate, a CR rate of about 50% in MDS and AML, and a median survival which was 12 months. But unfortunately, once again, in a randomized phase 3 studies, whose results we have not completely seen, but they seem to be negative. So once again, disappointing results, especially in a situation where prognosis is very poor. So what are the reasons for failure? Well, it could be that drugs are ineffective indeed. It could be that we have too small patient numbers. I mean, we have generally less than something like 100 versus 100 or 200 versus 200. It could be. It could also be, of course, that we have prognostic heterogeneity, and we can see that by reclassifying using molecular classification that those groups and may not be balanced between the placebo arm and the combination arm. Well, it could be also that efficacy in some cases is offset by toxicity. It may be the case. Insufficient follow-up, and the sabatolimab trial may show us with longer follow-up interesting results. It could also be unreasonable hopes based on response rate. And in particular, the issue of marrow complete response. And this is the reason why there was a recent update of the response criteria, which in particular tried to avoid the considering as response patients who just clear their blasts without improvement in cytopenias, because this may not be associated with more prolonged survival in many cases. So this is called a response, but eventually may not be completely a response. So we may have to reevaluate response using those criteria. And so still there's an important study whose results we're waiting, which are the Verona study, combining azacitidine and venetoclax, and this is during 14 days every every month, different from AML, where, as you know, venetoclax is used as continuous treatment. And this is the study. So high-risk patients randomized between AZA and azacitidine alone. We so far have seen only results of the phase 1b study, recently updated at ASH. And as I showed before, you have about 30% CR and well, close to 40% response with a hematological improvement. The recent criteria were not applied here, but it's clearly a 80% blast clearance, and most of those patients achieve an improvement in cytopenia. We know that this is associated to more myelosuppression as compared to azacitidine alone. But now we have a long-term experience in AML using AZA plus VEN. And when you use AZA plus VEN as compared to AZA, you have more myelosuppression, but response occurs earlier, and this is also the case in MDS. So eventually the cumulative duration of myelosuppression is less than with azacitidine alone. And it may also be the case in MDS. So we have now the survival, median survival, about 27 months. So it's a bit difficult now, of course, we are all waiting for the results of the phase 3 studies, of course, hoping that at least some patients will benefit. It could be, for example, that those with TP3 mutation, the biallelic one, do not benefit, like in AML, in terms of survival, but many groups may benefit. But of course, we really are waiting for that. So the last ones are the targeted drugs. And we unfortunately have very few targetable mutations in MDS, like in AML. So IDH1, IDH2 probably are the best targets so far. We have the GFM1 trial for IDH1, one trial with IDH2 with respectively ivosidenib and enasidenib, using either in patients who failed azacitidine, patients who are treated first line, this is cohort B, or patients who are low risk with anemia resistant to EPO, which is cohort C. And just to show the results, particularly of cohort B, which are relatively important in this case with ivosidenib, but they are also reproduced with enasidenib, 91% responses and 46% CR, and with a median survival which was not reached in this cohort B of patients with high-risk MDS treated up front, and with single-agent ivosidenib, and many of whom were bridged to transplant by just single-agent ivosidenib. So I think it's really, results are less favorable in patients who are treated second line. And those results have been obviously also shown by the US group led by Courtney DiNardo, either in combination with azacitidine, as you can see, 74% responses and median survival of 26 months, using the combination with azacitidine. Now, less favorable results post HMA failure, 35% response, but still median survival of 20 months. So it's obviously promising. We also know those drugs are not myelosuppressive as compared, for example, with venetoclax. And we hopefully will reproduce with MDS the results obtained in AML with the combination of azacitidine and an IDH inhibitor, like here with ivosidenib and here with enasidenib. So it certainly is promising in this group of patients. And I think most groups now tend to have rapid response on NGS, on targetable drugs like, on targetable mutations like IDH1, IDH2, FLT3. And we have them, for example, in 2 days, which allows us to orient the patient with for such combination of HMA plus IDH1 or IDH2 inhibitor. So this is quite promising. And with this, I'd like to acknowledge the department I'm part of in Paris, the French MDS group, which is mainly a group which activates clinical trial in the field of MDS, CMML. And we cooperate with our colleagues in Europe, especially in Italy, Spain, and Germany through the EMSCO consortium. And thank you very much for the invitation once again.
Thank you very much, Dr. Fenaux, for comprehensive talk, very excellent overview. Is there any questions or comments? Okay. If not, thank you very much. It's a very nice introduction, Dr. Fenaux, in very early morning in Paris. Thank you very much.
Thank you very much.
Okay, move to specific treatment for high-risk MDS. And next speaker is Dr. Garcia-Manero. He's going to talk about antibodies and BCL2 inhibitor for high-risk MDS. So, Dr. Manero.
Thank you. So I was asked to talk about new drugs, but actually you heard amazing talk by Dr. Fenaux, and actually I'm going to focus on BCL2, that I think is probably the most relevant issue coming hopefully to our practice soon. So these are my conflicts. Okay, so we are all grateful. Actually, it's a great privilege for me to speak after Dr. Fenaux because he's been such a great leader, and he actually led this really fundamental study in our field, this 001 trial that actually, unfortunately, 14 years later still is the standard of care for high-risk myelodysplastic syndrome. So the question is, as you heard from his talk, can we do better? And so far, we have not been able to actually demonstrate this issue. So you heard beautiful presentation in terms of a lot of these issues. We work first with HDAC inhibitors, trying to exploit synergism in terms of epigenetic deregulation of these genes. Multiple studies, all of them fail. The pebonidostat, the APR, etc. Actually, if you have time and you're bored, you may want to read that review in Lancet Hematology, where actually I predicted hopefully, what happened to most of those studies except one. We'll see if I'm right on the last one. So as Dr. Fenaux was saying, there's actually one doublet that is still up there, that is the combination with venetoclax. So on the original version of this presentation, had a lot of slides trying to convince you that there is some rationale to combine a hypomethylating agent with a BCL2 inhibitor, but the reality is that this comes from the experience with the Viale trial that has been transformative in acute myeloid Jones leukemia and now represents the standard of care for those patients that are not candidates for induction chemotherapy. Now, one thing that I believe it was very relevant from this Viale study was not only that it told us that there's improvement in survival with this combination, but we also learned that there may be a specific molecular subset of these patients that may actually benefit or not from this therapy. So actually, we started to learn perhaps where a combination like that could move into. So we started working on this very quickly, and I'm going to show you a couple of examples of data from MD Anderson with this doublet. So the first one was presented at IHA a couple of years ago, was published in Lancet Hematology by Dr. Bassinet, who was a fellow then, now he's one of our junior faculty, and was basically the phase 1 study of azacitidine with venetoclax. The study actually had a little bit of an ambitious design where we were looking at frontline and relapse disease, and actually we were also interested on understanding perhaps the proper dose of this drug. Dr. Fenaux emphasized the 14-day schedule of the venetoclax on the Verona trial. This is something that we see in the United States all the time, where sometimes patients with this disease actually get a little bit overdosed with the BCL2. So again, we incorporate a molecular profiling. If you can read that, you will see that there is actually a significant fraction of patients with P53 mutated disease. In my practice, this constitutes close to 40% of the patients that we see. It's just the nature of our practice. There's these issues of safety and tolerability. This morning or midday, there was this question about whether to give antibiotics or not. At MD Anderson, we universally treat all these patients with a triplet, with an antibacterial, antiviral, and antifungal. Actually, I don't think it's safe to do this kind of therapies, even with single agent in patients with high-risk MDS, but this is just our modest experience at MD Anderson. And if you do that, actually, you have actually a mortality rate that is close to 0%. You have to protect those patients in the first couple of months of therapy. And then there were 2 cohorts on this trial. Overall response rate, 87% in the naive group, 100% actually in the failure, but going back to Dr. Seidan's data, most of these were MCRs that probably, in this particular context of second line, had no significant value. And then when we started looking at the survival of these patients in the blue line here, you see with a short follow-up and a very small cohort of patients that the survival of these patients is actually not reached, and it looks quite positive. That was unfortunately not the case in the relapse refractory cohort. Then we started thinking about actually deploying what we call total oral therapy. And I'm going to show you a couple of slides, and I'm very proud actually of this work. Dr. Fenaux mentioned them a little bit briefly, so I'm going to go in a little bit of detail here. So from the beginning of the development of both azacitidine and decitabine, and sometimes you have to pay attention to the patients, the question was, do I really need to do 5 to 7 shots every 4 weeks for the rest of my life, whatever that means? So there was kind of like urgency to develop an oral compound of this class. And indeed, actually, there are 2 approaches to do this, as you heard earlier. So one actually is to combine the hypomethylating agent with a type of drug that inhibits this enzyme called cytidine deaminase. And those are the drugs that we know as STX727 and STX030. So 727 is actually approved in the United States, and actually I understand, correct me if I'm wrong, that was also recently approved for acute myelogenous leukemia in Europe. So I'm actually extremely proud of this work. And now, as Dr. Fenaux mentioned at ASH, we presented actually the final results of the phase 1 of 030 that actually is a true azacitidine-cedazuridine combination. So the goal here actually is to provide a drug that has the same PK/PD as the original parenteral drug. So we don't want to have a lower exposure for a longer period of time. We're just trying to, in a way, emulate the dose of, the pharmacological characteristics of the original azacitidine and decitabine, respectively. There's another cytidine deaminase called tetrahydrouridine. I've never used that. There's some data published on this. And then you have the other approach that many of you are familiar, that is actually to use the hypomethylating agents and combine. This is the CC486. This is the oral azacitidine. The issue here is that this drug has a very low exposure, and basically you have to give this drug for a little bit longer of time, and it's probably a different entity than the azacitidine that you have used in Japan for so many years. So this is basically the concept with the oral decitabine cedazuridine. Basically, if you inhibit that now, you're inhibiting the enzyme that is kind of inhibiting absorption and actually metabolism of this compound through the liver. And actually, in a number of studies with a colleague of mine that is here, Dr. Asap, we performed actually one of the most interesting phase 1 trials I've done, because we were actually looking at the ratios of the HMA, in this case decitabine, with this cytidine deaminase inhibitor, and we were spending time actually looking in quite a bit of detail at the PK and PD characteristics of each ratio, until actually we got the dose that you will see in a second was 100% or close to actually the exposure that you see with IV decitabine, and that's actually the ASCERTAIN trial. So this was a randomized study where we actually, after significant phase 1 and phase 2 efforts looking at these particular ratios, we wanted to demonstrate in a sequence, kind of in a specific fashion, that this drug actually had the same characteristics of IV decitabine. So here what we did was randomize between starting first with the IV decitabine, followed by the oral decitabine cedazuridine, or vice versa. And basically, this kind of designs allows you to do intra-patient dose kind of comparison, and you basically know with quite a bit of certainty whether you're absorbing this drug or not. And I think the results actually were unexpected, were kind of almost perfect. Actually, when I review a paper and everything is like 100%, I'm thinking there's something wrong here. So, but the reality is that the data was actually almost identical to what you saw with the IV decitabine. And actually, I don't think I have the plots for the induction of hypomethylation, but what was remarkable actually is that actually was almost identical with what you see with the IV decitabine. Of course, this is nice, but the question was, is this drug really active, right? We're getting levels in blood, etc. It induces global hypomethylation. But actually, as we started putting this data together, you see that this compound actually has significant clinical activity with a CR rate of around 22% or so. Actually thinking, okay, this drug actually probably is similar or pharmacologically identical to IV decitabine. And actually, the FDA agreed with us, and a couple of years ago granted this drug approval in the United States for the same indication as IV decitabine, and was followed by this study in Europe that now is allowing to give this drug in patients with acute myelogenous leukemia. So when we generated this data, then the question was, can we start developing some type of what we call now total oral therapy? And of course, the logical next step was to combine the oral decitabine cedazuridine with venetoclax. This data was presented at the EHA meeting last year, was published a few weeks ago in Lancet Hematology by Dr. Batailler, one of our senior fellows in my department. And I think this data is kind of interesting. Here, for some reasons I don't have time to discuss, we were kind of forced to use this 14-day schedule of the venetoclax. There is a lot of dose modification here if you're using an azole. That is something that we use all the time, and depending on what azole you use, etc., there may be different doses. And again, we had a number of cohorts based on the dose, not the number of days that we picked. With this particular combination, we became smart in terms of actually profiling these patients. And there is a detail there that I learned from Dr. Komrocki, one of our great colleagues and leader in the field, that is that it appears that these patients with AXL1 mutations actually are quite sensitive to this venetoclax type of combination. So as you can see there is a little bit of an enrichment of that patient population, but also like 20% patients with P53 mutated disease. This question of the toxicity, etc., comes all the time. Yes, these are myelosuppressive, but the reality is that in our hands, the mortality rate at 4 weeks is 0%, and at 8 weeks is 3%. Now, we follow these patients, we give them antibiotics, they're really taken care of. You cannot do this and say, come back in a month from now, because you may be in some type of trouble. And then we go to the activity of this compound, and I think it's quite important. So the overall response rate, and this is using pre-23 criteria, it's actually around 95%. With a CR rate that you see there that is actually quite significant, around 35 or 40%. What is interesting also is that we're documenting complete cytogenetic responses in this group of patients treated with these therapies. And actually, we're putting together with Dr. Sasaki, who is one of our faculty members from Japan, actually the impact of the cytogenetic responses in this group of patients. You see there actually that the time to response is quite fast. And interestingly, as Dr. Fenaux was alluding, actually a significant fraction of these patients, close to half of them, actually were able to successfully go for a stem cell transplantation. So right now, with the follow-up that we have, we don't have achieved a median survival. I guess the follow-up is short, and again, this is a small pilot trial, but I would think that this data is quite positive. But we're also learning. Yesterday, there was a quite of discussion in terms of these P53 mutated patients. They do indeed respond, and I don't know exactly what happens with the transplant, but the reality is that the survival is less than a year. That is actually what we're seeing with any doublet or with single-agent hypomethylating agent. In contrast, if you are mutated for this AXL1, actually these patients do extremely well. And then there is another issue that I think Dr. Fenaux was alluding that I think is quite important, is this concept of total therapy. So now we have a powerful doublet that is actually quite easy to deliver, right? This is total oral therapy. Just take a few pills during the month, and now you have a great rate of response. And what is happening is that a lot of these patients are candidates for transplant, and as you see here, those patients that get there, actually so far they have really an outstanding survival. So this is very important, and I don't see just this kind of concept as a mere bridge to transplantation. I think there is something beyond that phenomenon. As Dr. Fenaux said, there's an international phase 1 trial. This is a very important study. It has been ongoing for many, many years, and I think there are many different countries and investigators involved on this. That was kind of like the prodrome to like this Verona trial. Now, the study actually, if you allow me, was a little bit of a tragedy, because the study actually started, if I recall right, around the time of the MDS Valencia meeting. I don't know, Steve, what year was that, but actually it took quite a bit of time for this study to get going, etc. And part of this is because there were some early complications in some patients that were not treated with prophylactic antibiotics. And that actually delayed quite a bit the development of this study. There were issues with the dose and the schedule. We should have actually this doublet already approved in patients with myelodysplastic syndrome. So supportive care is fundamental, and this question of whether you should do this or not, if you want to use these therapies, this is actually what you have to do. Now, the data from this phase 1 trial is maturing very, very nicely. So again, similar to what you just saw with this oral doublet, the overall response rate is around 80%, the CR rate is around 30%. Now, if I had given this talk a couple of years ago, prior to this pevonidostat trial, I will tell you, okay, this is 100%, this is going to happen. But you know from the Panther trial, actually, that the CR rate was 30% on the control arm. This is a study led also by Dr. Ades and Dr. Fenaux and Sequeres. So now we have a little bit of uncertainty in terms of what is the true CR rate that is going to take you to the finish line. Now, the data in terms of survival, again, looks very positive with a median survival there that you can see of around 16 months or so. But the reality is that is this better than single agent? We really need to come with, sorry, this is the median survival is around 26 months. That was the event-free survival. So the bottom line is that we're seeing numbers that look really, really positive, but the question is, are these really numbers that are going to take us to an approval of this doublet or not in patients with high risk disease? Now, this is looking at the different type of responses. Interestingly, here actually MCRs with a 22-month survival. That's actually maybe not that bad. And there is another issue that similar to the oral combination that I showed you from the MD Anderson, in this study, we also followed those patients that went for a stem cell transplantation. This was presented at the ASH meeting also a few months ago. And again, you see this same picture. Those patients that respond go to transplant. Now they're starting to have survivals that potentially could be longer than you will expect with a single-agent hypomethylating agent. And it goes back to this issue of this total therapy and how we actually kind of incorporate all the tools that we have to safely treat these patients. Dr. Fenaux showed how we have improved on our transplant outcomes and modalities. This is actually quite significant because now we can transplant older patients with actually kind of mismatched type of donors, and we have these good responses. So the pool of patients that are transplanted, at least in my centers, has increased significantly. So therefore, if this math applies, that curve of the total therapy should really take us perhaps potentially to longer survivals. The reality is, this is all very nice, but we need to see the results of this trial. So everybody's waiting for this Verona trial that also Dr. Fenaux alluded. This is going to be a really fundamental trial in our field, and I think we're all really expecting these results. Now, 2 words on failure. Dr. Seidan here actually published the results of an international study kind of adding back venetoclax to this group of patients. This data actually probably is like at the limit of what you could consider positive or negative. I think this kind of data in second-line HMA failure is very important because we really need to start thinking about, if particularly Verona is positive, what kind of studies we're going to be doing for second line. We kind of repeated the same in our studies at MD Anderson, and we saw kind of the same type of signal with a survival of around 8 months or so. So we are not sure really that this add back is going to be really a signal. But our group actually has developed quite significant expertise in kind of following these patients sequentially with this single-cell RNA-seq technology. So this is work by Simona Cola, who is my partner in the section of MDS at MD Anderson. And basically, we are developing actually significant maps of perhaps sensitivity and resistance to these compounds. And actually, here, what I can tell you is that in a way, we could predict who may be sensitive or not to some type of BCL2, MCL1 type of approach, or actually some type of other intervention. So I would like to see our community building more of this kind of studies sequentially through these clinical trials. So basically, what she found is that there are these 2 kind of phenotypes that you may be familiar, this GMP, CMP, and actually the RNA signature of these cellular compartments are actually totally different, and the vulnerabilities that are represented by these RNA studies may suggest different sensitivities to different therapies on these patients. In conclusion, what I think I showed you, that there is no doubt that this combination of HMA venetoclax is active in high-risk MDS. Again, we should all wait for this Verona trial to really demonstrate what is the impact of this combination on the natural history of this disease. As you heard from Dr. Fenaux, there is actually significant tools now for molecular targeting, but I will argue also that we should expand on this kind of cellular single-cell techniques. Maybe some potential role for HMA failure, very important, as was discussed also early, in terms of peri-transplant approaches. And I think actually the field is really going into triplets. I mean, we have this already in AML, thanks to an alliance that we have with Aztec's Taiho, where we have combinations of oral decitabine cedazoline plus BEN plus IDH1, IDH2, FLT3, actually menin inhibitors. These are extremely powerful. So the future for these patients is going to be all total oral therapies. But I would like to end with kind of maybe a question to the group, as we think that this is kind of like a fraternity of like MDS people. That is, actually, what happens if this Verona trial is negative? So I think Dr. Fenaux was actually talking a little bit about this, but not really focusing on this. He's telling us about the CPX, etc. This is nice. But actually, I think that if this study fails, whatever that means, the community is going to have to think about what to do next. And we're going to have to think about whether an HMA is going to be the backbone that we're going to use to really show an improvement in overall survival. To be honest, I would like to see a positive study before I retire. So, and there's no study doublet that is actually kind of ongoing that will read in 10, 15 years, if you think about this. So this is very important. So we hope this Verona is positive. If not, we really need to think about, is there an alternative way to treat these patients? We really need to improve survival in patients with high-risk MDS. And with that, I really want to thank you for this opportunity.
Thank you very much for excellent talk.
Guillermo, that was awesome. I have a question to address your last point. What if Verona fails? I think it really depends on how that study is negative, if it's negative. If we have a lot of treatment-related mortality, for example, perhaps the venetoclax dose is not right. Maybe there is a way to modify that and still have it benefit as a combination.
Actually, I totally agree with you, because I will argue that potentially a dose of schedule of 7 days will be quite acceptable in this disease as opposed to 14 days. I totally agree with you on that.
Hi, Takamaeda from Kyushu University. So from biology point of view, if you can combine navitoclax and MCL1 inhibitor, I mean, basically, I don't know about PP3, but they should kill all the cells. But I was surprised to see MCL1 inhibitor is still on the table. I would appreciate it if you could mention more about the current status of MCL1 inhibitor.
So in my opinion, this is actually a small tragedy, because these drugs are actually, to my knowledge, they are not really in development anymore. We had a study with this AMG 176 compound, I think that's the number, but basically MCL1 inhibitor that was stopped by the sponsor. Of course, there are some signals of cardiotoxicity, things like that, but the reality is that, Dr. Madea, you're totally correct, that actually you could conceive those patients, particularly on that BCL2 sensitive pathway, that could be rescued with a combination actually of an HMA plus the MCL1 inhibitor and venetoclax. And we demonstrated that in that Nature Medicine paper. I'm afraid that there's going to be no clear drug development of MCL1s moving forward. So it's actually sad, and I'm not sure it's all about the toxicity. Maybe some other factor that drug companies think when they develop drugs.
Okay,
that's a very important question.
Okay, any questions, comments?
Thank you very much.
Okay, thank you very much. So next speaker is Dr. Yasuhito Nannya. Title of his talk is Other TX. So please.
Okay. I'd like to express my gratitude to organizers and chairpersons for providing me with the opportunity to have this presentation. I will talk about current status of azacitidine treatment, real world and recent findings associated with efficacy and azacitidine treatment. This is my UI. I think it is not necessary to describe the AZA-001 trial in detail. Azacitidine was introduced 15 years ago, was quickly established as the standard of care for high-risk MDS. The right panel shows the main outcomes of 16 azacitidine monotherapy studies summarized by meta-analysis. And this shows that CR and PR is achieved in 16 and 6% respectively, meaning that only 1 in 5 patients will achieve responses. In addition, the duration of response is only 10 months, and the overall survival after azacitidine monotherapy is 16 months. Also, azacitidine is a breakthrough drug that has changed the clinical causes of high-risk MDS, yet only a limited fraction of patients with high-risk MDS benefit from this drug. There are studies that have analyzed the use of HMA, hypomethylating agents, high-risk MDS, outside of clinical trials, so-called real-world data. JRSG CS11 is the observational registry of high-risk MDS conducted in Japan. This data was provided by Dr. Usuki. About 54% of high-risk MDS were treated with azacitidine, and the overall survival in the other treated group was 15.3 months, which was shorter than the overall survival of 24.5 months in the other 001 study, although I think direct comparison would be inadequate. There are other real-world data of other treatment reported in other countries, and all of these registries invariably show inferior outcomes compared with other 001 trial. In addition, more than one-third of real-world patients drop out from azacitidine treatment before cycle 4, which is associated with poor progression, disease progression. This reflects differences in inclusion criteria between clinical trials and real-world data. And the result is that real-world data have not been as good as in clinical trials. Furthermore, the outcomes after other treatment failure are poor if not salvaged by stem cell transplantation. Thus, azacitidine monotherapy has not produced satisfactory results. Thus, these findings highlight a significant unmet medical needs for effective treatment for patients with higher risk MDS. This figure illustrates the molecular abnormalities that occur in MDS and the targeting drugs that act against these abnormalities. To overcome the unmet needs regarding HMA monotherapy, combination therapies of HMA with various agents have been tested. Drugs circled in red are those for which combination treatment with demethylating agents was tested in phase 2 or phase 3 trials. Thus, many of agents described here target molecular abnormalities other than DNA methylation, and it is rational to attack multiple targets with different pathological mechanisms simultaneously. This table summarizes the combination trials, including azacitidine in phase 2 and 3 trials. Among these, the combination with venetoclax was introduced by Guillermo in the previous talk, and this is not the purpose of my talk to introduce them one by one, because I expected previous two speakers will cover most of them, and they actually did in a perfect way. Even in the current trend of development of combination trials, we should continue to make efforts to improve the effectiveness of azacitidine itself. So here, I'd like to present recent findings on the prediction of azacitidine efficacy, resistance mechanisms, and how to overcome the resistance. First, I talk about prognostic factors of other treated cases. First, this is a study design. We enrolled 449 cases who were treated with azacitidine for higher risk MDS. We conducted genetic studies before and after azacitidine treatment, and we explored the correlation between these genetic profiles with clinical outcomes, overall survival, and short-term response. In univariate analysis, multi-hit TP53 mutations, higher risk karyotype risks, 7TP-LOH, and 5q deletion were significantly associated with complete remission rate, whereas mutations in ASX1 and STAG2 predicted a lower response. In multivariate analysis, multi-hit TP53 mutations, higher karyotype risks, ASX1 and STAG2 mutations remained in the model, although none were statistically significant. So this is a summary of this analysis predicting CR. We next examined whether post-treatment data would improve the predictability of IPSS-M. We first showed that the IPSS-M score and age, clinical response, and the size of the largest clone after treatment constituted independent components of the multivariate model for overall survival. Based on this model, we constructed a scoring system, which we named PSS-AZA. This novel model clearly stratified this cohort in terms of survival. We showed stepwise improvement of predictability of these models with increment of C-index score from PSSR to PSSM, further to PSS other. Next, I'd like to show resistant mechanisms of azacitidine and decitabine. Here is a list of currently known causes of resistance of hypomethylating agents. And among these, I will pick up these mechanisms. First, I talk about influx and efflux of hypomethylating agents and the impact of their expression on resistance. HENT is a key regulator of HMA influx, which was revealed by CRISPR-Cas9 screening, while inhibiting the function of HENT by artificial knockout or other means can result in drug resistance. It is controversial whether expression of this enzyme actually accounts for drug resistance in the patient population. We have contradictory results. Similarly, ABC transporters has been suggested to be involved in drug efflux. However, it is not known which of the main types of ABC transporters are actually involved in, and to what extent their overexpression actually account for the resistance. Cytidine deaminase that was introduced also by Guillermo. Deaminase both azacitidine and decitabine and rapidly inactivates both products into uracil counterparts that do not have function to inhibit DNMT1. The expression of these enzymes is actually induced in MDS cases by HMA exposure and serves to inhibit drug activity. CDA is highly expressed in gut and liver, thus impeding oral availability of hypomethylating agents. Though oral administration of decitabine is only achieved with the help of CDA inhibitor and cetazolidine with decitabine. This combination, STX727, is already approved for MDS and CMML by FDA and is under development also in Japan. BCL2L10 belongs to the BCL2 protein family and can interact with other members of BCL2 protein family. Overexpression of this gene has been shown to suppress cell apoptosis, possibly through the prevention of cytochrome C from the mitochondria. In the process of establishing azacitidine-resistant myeloid cell lines, the expression of BCL2L10 was enhanced, suggesting that this molecule is involved in azacitidine resistance. Actually, the percentage of BCL2L10 high-expressing cells increased in other resistant patients compared with other sensitive patients. And additionally, BCL2L10 level in patients at onset, 6 months and 9 months after azacitidine treatment significantly stratified patients into groups with different overall survival. Thus, BCL2L10 positive cells may be a biomarker for azacitidine response and overall survival with a potential impact on clinical practice. SAM-HD is an enzyme that was known to inactivate RC triphosphate by removing phosphate groups. High expression of this enzyme is known as a biomarker for poor outcomes for AML cases treated with RC. It is known that there are various substances for this enzyme other than RC, and DAC-TP, the active substance of both azacitidine and decitabine, are also known to be to reduce its activity by removing their triphosphate groups. Thus, SAM-HD1 can be a clinically relevant resistant factor of hypomethylating agents. Therefore, high expression of SAM-HD1 may confer resistance to decitabine. Actually, SAM-HD1 was highly expressed in bone marrow from a patient who showed resistance to decitabine. An analysis of 36 decitabine-treated patients showed that patients who did not reach CR showed propensity to have higher score, that is to say higher expression of SAMHD1 by immunohistochemistry. In addition, drug resistance of primary blast cells from AML cases, as measured by IC50 value for decitabine, achieved positive correlation with SAMHD1 expression levels. Thus, SAMHD1 expression was correlated with resistance to decitabine, but not to azacitidine. SAMHD1 expression is involved in resistance to decitabine, but not to azacitidine. So let us consider the reasons for this. About 10% of azacitidine is converted into deoxyhome by ribonucleic reductase and incorporated into DNA, while the remaining 90% is converted to azacitidine and incorporated into RNA, where azacitidine metabolites are assumed to exert anti-tumor effects by inhibiting protein synthesis. Therefore, when SAMHD1 expression reduces, the amount of hypomethylating agents incorporated into DNA, thereby reducing DNMT1 inhibition, decitabine activity would be greatly affected, whereas azacitidine is cell active because the remaining 90% can exert its effect against RNA synthesis. It's just a hypothesis. A possible therapeutic strategy to restore sensitivity to decitabine is to suppress SAMHD1. Transient reduction of SAMHD1 expression in patient-derived primary AML cells conferred sensitivity to decitabine, whereas sensitivity to azacitidine was largely unaffected. To investigate whether SAMHD1 expression differentially influences the anti-tumor activity of decitabine and azacitidine in vivo, immunodeficient NGS mice transplanted with human AML cell lines genetically engineered to express different levels of SAMHD1 were treated with decitabine or azacitidine. Mice transplanted with THP1 knockout cells survived significantly longer than mice transplanted with THP1 control cells in response to decitabine. In contrast, no SAMHD1 dependency was observed in the survival of azacitidine-treated mice. Aza inhibits DNMT1 function when its metabolite, aza-DCTP, is incorporated into DNA. However, if a sufficiently large amount of DCTP is present in the nucleus, the amount of aza-DCTP that is incorporated into DNA is reduced and inhibition of DNMT1 is attenuated. De novo synthesis is a mechanism for providing sufficient amount of DCTP in the presence of azacitidine and plays a role to circumvent DNMT1 inhibiting function of azacitidine. Therefore, de novo pyrimidine synthesis is one of the resistance mechanisms of hypomethylating agents. So, inhibition of de novo pyrimidine synthesis can be a method to overcome resistance. DHODH is a key enzyme of de novo pyrimidine synthesis and is inhibited by PTC299. When the supply of DCTP is stopped by applying PTC299, higher amount of other DCTP would be used for DNA synthesis. In fact, when PTC299 is applied to MDS cell line, MDSR, increased uptake of other DCTP is observed. Other DCTP is a DNMT1 inhibitor and thus kills MDS cells. As a result, when PTC299 is applied to MDS cell lines in the presence of decitabine, it synergistically enhances the cytotoxic effect of decitabine and azacitidine to less degree. Thus, synergistic cell killing effect of HMA and PTC299 can be observed in actual MDS patient cell lines, but in normal CT positive cells. This provides a therapeutic window for the strategy. In addition, this combined treatment of PTC299 and decitabine prolonged survival of xenograft model of MDS cell lines. Thus, the efficacy of HMA therapy would be enhanced by inhibiting de novo pyrimidine synthesis using PTC299. So this is a summary. Azacitidine constitutes standard of care therapy for higher risk MDS. However, its effectiveness is yet insufficient and leaves room for improvement. A lot of combination trials are being developed with drugs that have different mechanisms. Treatment multiple mutation profiles and clone size reduction after several courses of azacitidine treatment predict outcomes of this drug. Elucidating refractory mechanisms of hypomethylating agents provides both predictive marker of efficacy and clues of novel methods to overcome the resistance. Enhanced expression of CDA, SAMHD1, BCL2L2, and de novo pyrimidine synthesis confers resistance to hypomethylating agents, and their inhibition constitute attractive treatment options to enhance the effectiveness of HMA. Lastly, I'd like to thank all the collaborators. Thank you.
Thank you very much. A nice talk, including resistant mechanisms for HMA. Is there any question? Okay.
This was really fantastic talk. So this question I should ask myself, but I don't know the answer. So you showed very nicely that the XL1 mutation actually is a poor predictor of response when you use single agent. So we knew that actually. But then when we combine with the BCL2, we see kind of like the reverse, and there are multiple series showing the same. I don't have an explanation. Do you have any idea about this or any data?
Not yet, but I think it's an ideal idea worth trying.
Thank you.
Very nice talk. Just a question regarding the PTC299 compared to hydroxyurea. Is there some specificity of this inhibitor?
I'm sorry, I don't know the details of this drug specifications, so I'm sorry, I don't have the data.
Okay, thank you.
Okay. Do you have any candidate which suppress the SAMHD1? Do you have a candidate molecule or agent? Maybe confidential.
In that experiment, SAMHD1 was suppressed using siRNA as a means. So there are some hurdles to develop the method to inhibit this enzyme as a drug.
Okay, thank you very much. Okay, so thank you very much, Dr. Nannya. So next speaker is Dr. Ogawa. He's going to talk about the CLK inhibitor. Okay, please.
Yeah. So how to change the pointer? Okay, it's okay. So thank you for kind introduction. And so I'm very happy to be here and present our recent work, which is something to do with some drug development targeting the suppressing machineries. So because many of you expect that I'm talking about some other pathology of the MDS, not drug development, but very recently I'm more and more interested in the drug development because at the end of the day, our ultimate purpose is to cure patients, of course. So in that point of view, so I'm actually, I was not able to access to that field, but 10 years ago, a young guy sitting here from Takeda Pharmaceuticals, Daisuke Morishita, all of a sudden came to my lab and proposed some collaboration. Then we are now developing in total 3 drugs, and obviously 2 drugs are now in phase 1-2 clinical trial in the United States. So the topic of my talk today is one of them, CDX721. So this is CDX, so this is my COI. So I am so advisor role of Kojak Therapeutics and accept some grants. So many years ago, we and other groups reported frequent splicing factor mutation mild neuroplasms, particularly in those having mild dysplasia. So anyway, so depending on the subtype, splicing factor mutations mutated in 40 to 60% or something, and also in MDS, and also 10 to less than 20% of the cases of the AML. So many of you are very much familiar with this. So this splicing mutation involves at least 8 components, majorly 4. And many of the 3 of them have the mutation hotspots suggesting some neuromorphic functions, and other GRSS2 is probably loss of function mutation. But importantly, all these mutations heterozygous, and they very much do not likely to co-occur, suggesting some kind of negative selection, meaning so synthetic lethality. If any of 2 splicing mutated cases, show loss of function, so it's going to be the highly toxic to not compatible with cell viability. So this lead to the concept, probably many of you are familiar with this. Splicing factor mutated cell is compromised splicing factor, but splicing machinery. But when we further inhibit this splicing machinery, it would lead to the cell death, not compatible with cell viability. This is the concept of synthetic lethality. And on the basis of this concept, several people are trying to target the splicing factor machinery. So several drugs have been developed to inhibit spliceosome. So majorly targeting SS3B1, and other drugs also target other factors, RBM39. But anyway, so unfortunately, none of these compounds failed to show its clinical efficacy at this moment. So, anyway, we embarked on the new project targeting the other component of splicing machinery. It's CLK. CLK kinase is a serine kinase that phosphorylate a number of the spliceosome splicing factors. They are sharing the RS domain. RS domain means arginine and arginine. So anyway, so this is a rich target of the serine. So this is a target of the this CDX. Why CDX is important? This is because splicing factors need to be phosphorylated before they works. So our target is CLK. Actually, Takeda Pharmaceuticals, this development first generated in Takeda Pharmaceuticals. But before the discovery of splicing factor mutation, they stopped the development of this drug. But fortunately, our papers came out, and they decided to, it's restart this compound. So this is CDX. One is a highly specific CLK inhibitor very high specific selectivity compared to other kinases. And the CLK was inhibited is very high, very low concentration, 0.46 nanomolar for the major target of CLK2, which is mainly expressed in hematologic cells, hematopoietic cells. So actually, this compound strongly inhibits the many SLS proteins, including SL4, 6, 3, 2, and they induce, they inhibit splicing and cause abnormal splicing, but mainly skip the exons in a dose-dependent manner. And so actually, this drug inhibits cell growth, the growth of cell line. This is not supranuclear mutated, but anyway, this shows so some cytotoxic activity at 25 nanomolar. And with IC50 of 25 nanomolar. And also, this drug is also effective for xenograft of AMD before in a dose-dependent manner as well. So the initial our hypothesis is that this drug is more sensitive to the splicing mutated cells. So to show this, we introduced K700D, one most common cell mutation in TK6 cell, and this is a B cell derived cell. But anyway, so we compare the sensitivity of these two to isogenic cell lines. You can see that in SL7 mutated and SSR2 mutated cells, both cases, splicing mutated cells shows more at a higher sensitivity to the CDX172. So this is a kind of a proof of concept. So it's okay. Our strategies are working. And then next test is the sensitivity using the primary leukemic cells. Until now, we tried nearly 70 cells, primary cells. And we found, so, okay, these cells are sensitive to splicing factor mutated as IC50 is 10 to minus sign. And but also they show the sensitivity to splicing factor unmutated cells. Even though the TP53 mutation mutated cells are less sensitive, unfortunately. But anyway, this drug shows the so high sensitivity to most of the primary cells we tested. So, but it is interesting to this yellow cells. Unfortunately, this is before publication. I need to I can't unmask this, but so some. But what I want to say is this is some differential sensitivity to different cell types mutation. So next test is the efficacy in primary patient-derived xenograft. You can see there's some this drug is sensitive to a broad range of PDX cells, including splicing mutated and unmutated cells, like shown here. After the drug administration, so subcutaneous tumors are almost gone. And interestingly, this drug also shows activity to non-hematopoietic cancers, solid cancers. So we show the high sensitivity to ovarian cancers. And we now testing a broad range of cells. And I would say this drug also not only sensitive to effective to hem malignancy, but also shows a broad range sensitivity to solid cancers. So we next look at the correlation between the abnormal splicing and drug sensitivity in PDX model. As you can see, the more the splicing abnormality, more sensitive to sensitive. So this is and also we look at the we compare the abnormal splicing before and after drug administration. We observe that there is two type of response. One group is show very high shows a very high splicing change. Others, almost no splicing. And interestingly, this is correlated with the drug sensitivity. The more those cells shows more splicing abnormalities, more sensitive. So like here. So this is not our work. So this is the published result of phase 1 trial. So this is those escalation studies. This trial shows 150 milligram of the so the essentially they increases the drug once 175 milligram. But at this point, they show the thrombocytopenia, so they decrease the drugs. So now the determined drug is 150 milligrams, and then further reduce the drug dose to 70 milligrams because of the development pneumonia and something like that. So anyway, so at this dose, we observe the this is just phase 1 trial, but 5 out of 8 cases with highly refractory AML shows achieve the CR or CRI. So the one case, this is 73 years of age, I remember. So this is so patient enjoys long-term response, even though this before the treatment, there's really highly selective AML. So and also the phase 1 trial shows that 2 cases with ovarian cancer shows sensitivity to this drug. So anyway, there are promising phase 1 result. So they are now moving on to the phase 1/2 trial in the United States, by the MD Anderson. So my friends, Garcia-Manero, Dr. Garcia-Manero has read this trials. But so finally, I say something because we first tried to develop this drug in Japan. So we took 4 years for phase 1 trial, and only 8 cases of AML has recruited. Oh my God! So it's like eternally. So we decided to change the strategy and going to United States. So this is a big problem with the drug development in Japan. So which I need to be somehow improve in the next generation. So so there some adverse effect is also important. No big critical adverse effect was observed, or even though some cases shows more than grade 2 adverse reaction. The major reaction, surprisingly, with the dose of 70 milligram and 100 milligram, then almost no hematological toxicity, just kill leukemic cells. Some cases shows significant tumor lysis after the administration of the drug. So the major toxicity or side effect is the nausea and vomiting. Very terrible nausea and vomiting was complained by the patient. So, but this need to be, I don't know. So this is, okay. So this is summary. CTX71 is another inhibitor of CLK family of kinases at very low IC50. So, and it is strongly inhibit the phosphorylation and cause huge number of abnormal splicing, and so it is effective in shows anti-leukemic effect and tumor effect in vitro and in vivo. And this is the drug efficacy is correlated with abnormal splicing, suggesting that the mechanism of cell killing would be the abnormal splicing machine inhibition of the splicing machinery. So we identified now very nice candidate reliable markers predicting efficacy of this drug, and which could be used to target the other cancer cells than hem malignancies. Thank you for your attention. No. This is a collaborator. And Dr. Akinori, Yoshida, and so Daisuke Morishita did most of the work. And so we provided the cell line from David Winstock. I thank all of the collaborators. So thank you for your attention.
Thank you for introducing your promising result. Maybe I should say congratulations. Any questions, comments?
Great study. One question. The splicing abnormalities induced by this CLK inhibitor and RNA aberrations, exon skipping and so on, is it similar to the spliceosome-induced genetic changes or like RNA changes? Or is it different type?
No. The target of the splicing, target of abnormal splicing different from those seen in the splice factor mutated cells. So this is much more strong. Of course, the splice factor mutated cells shows some abnormality, but this drug causes a huge number of abnormal splicing, not comparable with splice factor mutation, and mostly exon skipping.
And other question is, how do healthy cells behave? Do they recover from this, or?
Yeah, so of course this drug inhibits splicing of normal cells, but fortunately or unexpectedly, there is no severe hematological toxicity, no reduction of the WBC or red cells and platelet cells at this dose. Of course, at high dose, this drug inhibits platelet counts. Hi.
Thank you, Seishi. Does it inhibit stem cells, mutated stem cells?
I don't know. Yeah, I don't know. We did not look at the stem cell fraction. Yeah, it's a good idea. Yeah, of course. Hi.
Very great talk. This inhibitor is mainly inhibiting the phosphorylation of the serine arginine splicing factor.
Yeah.
So I wonder if it is also inhibited as a non-splicing function of these factors.
Oh, it's a good question, and unfortunately, we cannot answer your question exactly. So, of course, we assume that this is a major target is CLK, no other kinase of hit. But nevertheless, we cannot completely exclude the possibility that this kinase inhibitor also have some off-target effect. So, yeah. But what is important? Anyway, this drug is sensitive to leukemia cells, and if the mechanism is different from the splicing factors, but anyway, so for me, it's okay. So as long as this is effective and cure patient, it's okay. So I'm sorry.
And just a quick question regarding the solid tumors. Independently of splicing factors, this solid tumor may have some neojunction splicing event independently of the mutation of splicing factor. So did you look at the spectrum of splicing events before and after treatment without mutations?
So abnormal splicing not necessarily confined to those cells carrying splicing factor mutation, but many cancer cells, including acute myeloid leukemia, show some abnormal splicing because we look at the nonsense mediated decay. So this pathway is activated regardless of the splicing factor mutation. So they probably cancer cells have many splicing abnormalities. That is not ascribed to the splicing factor mutation. So, but one of the possible mechanisms is that this abnormal splicing, so tumor cells, with high proliferation, needs high-speed transcription. But splicing factor, abnormal RNA splicing is occurred just RNA polymerase goes through. So but once this RNA splicing is failed, there is no chance to recover that. So those cells having high cell cycling, so like ovarian cancer and other cells, are very sensitive to the abnormal splicing inhibition. So this is one of the mechanisms what we are now in mind. So some data with abnormal splicing probably partly support this. Thank you.
Well, Seishi, my question is a complement of the question of Michaela, but I wanted to know whether you have any idea of the reason why ovarian cancer cells are highly sensitive to your drug.
I don't know. Our assumption is that ovarian cancer frequently shows high proliferation rate and MYC abnormalities. But this case do not have MYC amplification. But I don't know actually.
Thanks.
This is my totally personal interest, but you have completed the genetic analysis of MDS. So what is next? Metabolome or proteome or whatever you think?
So for the time being, the previous target is actually not malignancy, but some lymphoma targeting the BCM complex. This time, splicing factors, and we still stay on the splicing factors. But from now, we now do the different strategies that targeting negative selection, and we have potentially some interesting targets so some cancers like colorectal cancers and endometrial cancers, and but. It is, of course, it needs a lot of money to develop the single drug. So we need to be careful to select the targets. Yeah, but still, no idea.
Thank you very much. Thank you, Dr. Ogawa.
Thank you for your asking.
So last speaker of this session is Dr. Usuki. He's going to talk about the transplantation in Japan.
Thank you for introduction. And before starting my talk, I would like to express my appreciation to organizer for giving me the opportunity to present here. I represent the transplantation or practical therapy for high-risk MDS in Japan based on recent findings of Japan Adult Leukemia Group JARESG studies. JARESG has more than 220 centers and has conducted more than 50 clinical trials. This is my disclosure, and I'm going to talk about real-world data of MDS in Japan, then bridging therapy in transplant, finally, azacitidine treatment schedule, other 5 and other 7. Real-world data. The 5-year overall survival of MDS was reported to be 20% to 48% from France, UK, Netherlands, European countries, and US. But we don't have any Japanese-owned data because of lack of large population-based studies. So to clarify the Japanese patients' survival data, we plan to registry study called JARESG AML MDS CMML Clinical Observational Study, CS11. In that, all the patients who are diagnosed as AML MDS CMML in JARESG centers were registered. Total from 2011 to 2016, total 6,568 patients were registered, and after exclusion of inappropriate 409 cases, the final 2,747 MDS cases were available for analysis. And the patient number of MDS patients were less than AML, and ratio of patients number was 1.4, 1.0, and 6.066. Median age of MDS patients was 74 years old, and patient under 65 years old was only 20%, clear contrast to AML 42.2%. Male-female ratio was 2.261, male predominant, and therapy-related disease accounted for only about 10%. In IPSS, the lower risk patients were 59.6%, resulting the ratio of lower and higher risk was of 1.481. In IPSSR, the ratios were 0.791 and 1.41, according to each respective definitions. Compared to original reports, our Japanese cohort shows a lower ratio of lower risk MDS. The 5-year overall survival was 32.3%, median overall survival was about 2.2 years, and 5-year cumulative incidence of AML evolution was 25.7%. Those were comparable to previous findings from other countries. Sorry for busy slide, but risk stratification of IPSS, IPSSR, WPSS, and refined WPSS were validated and confirmed using our Japanese cohort. In our Japanese cohort, the most common treatment was azacitidine, which was given to about half of higher risk of patients. Second most common treatment was ESA, which was given to about 20% of lower risk patients. Transplantation is only given to 7% of the entire MDS patients. This result was already shown by former speaker, Professor Nannya, but anyway, with regard to result of azacitidine treatment in higher risk MDS, median overall survival was 15.5 months, which was much worse than those of other 001 trial, and which is rather similar to those of conventional care regimen, conventional care regimen 15 months. And the registry study from Dutch, Spanish, SER, US, and Canadian, those registry studies show these figures of median overall survival by azacitidine, and these figures are comparable to our results. And patient with transplant shows a better survival than those without transplant. Next is about bridging therapy in transplant. The transplant is only curative treatment for MDS, and this is the therapeutic algorithm for higher risk MDS by international expert panel. If patient is fit for transplant and has more than 10% marrow blast, the cytoreductive therapy are recommended before transplant as a bridging therapy. A large retrospective study demonstrated that the marrow blast percentage at the time of transplant had a great impact on the survival after transplant. With the goal of downstaging MDS before transplant, the azacitidine treatment alone produces the survival outcome similar to standard intensive chemotherapy as a bridging therapy. How about the comparing to upfront transplant without bridging therapy? With regard to intensive chemotherapy as a bridging therapy, several retrospective study from, for example, Fred Hutch and Italian Registry and Japanese Society, these studies shows no impact of intensive chemotherapy prior transplant compared to upfront transplant without bridging therapy on survival. So it should be considered there is no definitive evidence of survival benefit associated with administering cytoreductive therapy before transplant in MDS. Then what about azacitidine as a bridging therapy? Dr. Nakagawa and Professor Ishiyama, they analyzed clinical impact of bridging therapy in MDS-EB patients using Jersey CS11 data. From CS11 data, they selected 371 MDS-EB patients younger than 70 years old and collected new data from each participating centers and integrated them with the CS11 data for analysis. Half of patients were considered for transplant at the time of diagnosis of MDS-EB, and other half were not considered for transplant. In transplant considered cohort, 75% of patients actually received transplant, and 21.3% did not receive. And 3-year overall survival of the entire cohort was 23.9%, and this pie chart showed the detail of bridging therapy. Half of patients received azacitidine as a bridging therapy, and 18.2% received combination chemotherapy, and 17.7% did not receive any bridging therapy. Survival curve of patients who were considered for transplant showed the better survival with 3-year overall survival of 33.7% and 13.9% in patients who are not considered. And univariate and multivariate analysis showed the survival was associated with age, PS, IPSSR, and consideration for transplant. This slide shows the intention to treat analysis using transplant considered cohort. And these Kaplan-Meier curve by bridging therapy, and survival curve after adjusting for background factor, for example, blast percentage. The patient without bridging therapy showed better survival than those with azacitidine and with combination chemotherapy. And univariate and multivariate analysis showed the PS cytogenetics and transplant was associated with survival, and in bridging therapy, combination chemotherapy had a bad impact compared to upfront transplant without bridging therapy. In transplant cohort, including only patients who actually received transplant, the survival curve after adjusting for background factor, patient without bridging therapy had better survival than those with azacitidine and with combination chemotherapy. And sorry for busy table, but univariate and multivariate analysis of OS, PFS, and progression incidence, in addition to cytogenetics, PS, and blast percentage, the upfront transplant without bridging therapy had a significant impact on prognosis, including OS, PFS, and progression incidence compared to both azacitidine and combination chemotherapy. So, in conclusion, transplant-eligible patients with MDS EB should undergo transplant when clinically acceptable without delaying the procedure, and upfront transplant without bridging therapy may be superior to azacitidine and combination chemotherapy. Next is azacitidine treatment schedule. Azacitidine was proved to prolong the survival of higher risk MDS in phase 3 study, but the treatment schedule has not been fully determined. And since the 7-day treatment included a 2-day weekend treatment, so 5-day azacitidine treatment has been widely used, widely applied for MDS without solid evidence. So Professor Miyazaki, the president of this symposium, as a primary investigator, planned to compare other 5 and other 7 in randomized study to test non-inferiority of other 5 to other 7. Delta was defined as 11%. With this assumption, the 410 patients were needed to complete the trial. But unfortunately, because of poor recruitment, the trial was prematurely terminated. So we performed pre-planned interim analysis. This final interim analysis includes 201 patients who were registered. There is no difference between other 7 and other 5 in patient characteristics, except for WHO classification, in that the LIVE-2 patients were more in other 7 group. There is no difference between other 7 and other 5 in overall survival, leukemia-free survival, time to leukemia transformation. But by central review of diagnostic smears, 13 patients were diagnosed as AML, 9 in other 7 and 4 in other 5. This uneven distribution could potentially influence the judgment of progression to AML. So we decided to reanalyze the 150 patients with diagnosis of LIVE and LIVE-T confirmed by central review. And although there is no difference between these groups in overall survival and leukemia-free survival, the other 7 groups showed longer time to leukemia transformation than other 5. And this was confirmed by proportional hazard modeling risk analysis. So as a conclusion, although this trial could not provide definite evidence, the results support the use of other 7 for LIVE and LIVE-T. This is acknowledgement slide. Thank you for attention.
Thank you, Dr. Usuki. Any question, comment? This is specific Japanese cohort results. It's the same in the other countries. Bridging treatment efficacy or something. Trial results shows no bridging treatment is best choice before the transplant, right?
Yes, it's retrospective in some meanings. So there is a selection bias, and so physicians choose the treatment. So maybe.
Thank you very much. If there's no question or comments, I'm going to close this session. Oh, any comments? No. Thank you very much. I'm going to close this session. Thank you.